All right, let's rock. Let me
Uh,
get you to share your screen. Boom.
okay. All righty. I'm just gonna, like I said, when I go into share screen here, shoot, it's going to like I'm gonna lose chat and stuff too. So like, please just jump in, open, talk over me because I just won't be able to see a ton of stuff. Um, that makes it just way easier for me, I think. Why? Okay. Give me 2 seconds. Okay, perfect. All right. Good. You can see this beautiful screen. Okay,
Yep.
awesome. Like I said, everyone, please jump in, ask questions, call me out, tell me I'm wrong at any point. I don't mind being totally wrong about things, so please go ahead. So this talk originally was designed just about how we take research into the clinical setting, because that's a surface level idea. Like that seems like a very straightforward concept, but it's actually really complicated in practice. Like how do we actually take a clinical trial with hundreds of people and make it make sense to a one-on-one basis in clinic? So I always like to do just especially there's a recording, just a little about who I am, so people have an idea of who I am. I know it's a boring start. I'm a clinical intern at the Canadian Memorial Chiropractic College in Toronto, Ontario. And I'm currently actually located in a hospital. That's where my clinic is, and it's in a rehabilitation hospital, but we're not technically fully integrated, which probably shouldn't be that surprising, given that I am a chiropractic student, and there is definitely still some issues with integration and all that kind of stuff. But my background is in strength conditioning, a weightlifting coach specifically. So I've been coaching weightlifting for 9 years, and I've coached it from the very amateur level. I've coached it from the youth level to master's level, and from local meets to national level meets. So I'm also a self-described very amateur researcher, so involved in a few research projects right now, a couple that I'm leading, a couple that I'm most certainly stuck in the middle authorship group on. So a wide range of that. And then I'm also a self-described amateur statistics person. So my interests really lie in statistical methods and how we look at basically, do we know what we know what we're seeing? And then I think technically most importantly, what I am is what's called the head or director of research for ARMY, which is the Active Rehab and Movement Education Group. But head of research really just means I'm quality control. So I make sure that no one says things that are just wrong. That's really my job. That data doesn't say what it says I think it is. So this paper got sent out. This is, I think, a really, really insightful paper from Kari Tikkanen and Gordon Guyett about, and again, if people have read it, or hopefully people read it, if not, it's 2 pages, super short and really to the point. But their comment is that still to this day, even in medicine curriculum, and I know that sometimes chiro and PT and other related fields might not be quite as caught up sometimes, or behind or ahead, who knows. But their comment on medical curriculum is just that people do not know how to appropriately critically appraise and include research, because there's a lot to know in medicine. And I think there's also a lot to know in various aspects of PT. And I think there's enough to know in chiro as well. That there's a lot to try to understand on a clinical perspective before we even get into an integrating research perspective. But there's one paragraph that I really like, that I think is really important. And this is geared more towards kind of the outpatient PT or ortho PT chiro setting. So less so would be my knowledge about anything acute or neuro. That's well beyond my scope. But I think one of the nice things about this quote is that to engage in shared decision-making, clinicians must understand the magnitude of benefits, harms, and burdens associated with alternative management options. So we have to have an idea of what a relative effect is, and absolute effects, when they matter, when they don't. Otherwise, any of our direction of treatment kind of stuff seems a little bit misguided, right? If we can't justify what our clinical reasoning is for including a treatment approach, and how that might shift the likelihoods or the benefits of or probabilities of someone getting better, I personally really struggle with why we even do the intervention. And so that's what I really took away from this is if we're truly participating in shared decision making with patients, which is a vital aspect of informed consent, you got to explain why we're choosing one intervention over the other, why we're starting at point A, not point B. And what I think the first way we can do this, the first way that we can be really honest and open with the shared decision-making process is by knowing your prognostics. I know Derek mentioned that before we started. And this is the lens that I view every conversation with patients with, every shared decision-making, every informed consent that I do starts with talking about prognostics. So what do I think the prognostics of the condition that the person's experiencing with? What do I think their personal background and social experience is that could lend to the effective prognostics? But I'm very passionate prognostic guy. So here's a couple cheerleaders cheering us on. We have a smaller group here, so I'm going to put people on the spot, except for Geronimo and Derek, and they aren't allowed to answer because I think they actually know the answers to these already. So I'll put everyone else on the spot they want. What is median recovery for low back pain? Prognostics. Person comes in with acute low back pain. You've ruled out every single thing that is sinister, traumatic, significant trauma in the sense that there's true dangerous structure damage. What is your median recovery for low back pain?
4 to 6 weeks.
That's the golden answer. That is the answer that everyone gives. I think it actually might be a little less. So this is from the PACE trial. This is from actually the secondary analysis of simulated data of the PACE trial, but there's a 2-day difference. So PACE trial found median time to recovery was between 13 and 16 days. And the average time of onset to people being included in the trial was 9 days. So I think it actually might be on the lower end of that 4 to 6 that we get exposed to, especially for immediate recovery. And then obviously what I think is something that's really kind of important that doesn't somehow get talked about is just that, like, there's we're at day 6 and 20% of people are feeling better or self-classified as recovered. And that recovered in this trial meant that they didn't have pain for a week. So they enrolled in the trial and then, they didn't really have pain by 6 days into this tracking period.
Does this go into, I mean, I know you said 9 days when they were coming into the clinic from their thing, but did it do any stratification as to looking at the intensity of which they came in at, right?
No.
Okay.
Yeah. And that's a great point, right? Because we know that onset level of pain as a prognostic factor, right? People who are in more pain at first are less likely to get better quickly, right? There is some, that's a great point. I love this data that's also relevant is if we look at a systematic review out of Australia from 2020 that looked at what was the trajectory of back pain out of the ER, people came in at like a 7 on average, which makes sense. I would say 7 out of 10 back pain. That for a lot of people, that sounds like ER back pain to me, right? What I love about that trial is 24 hours later, the average is 4.4, right?
Right, but that's the earliest onset. I mean, in most of my clinical experience, I'm not seeing people within that first 16-day window or that first whatever. They've gone through multiple things, been told to take these pills for 2 weeks. And if that doesn't work, then we'll do something else. And so I'm seeing them 3 or 4 weeks in. And if they're still at a 7 at 4 weeks, that's a whole different talking point than some of this other data.
Oh, absolutely. Absolutely. And that's where, again, you have that integration to try to understand like who is the person in front of you, right? And obviously that definitely exists to a certain degree, and there's definitely like worthy debate about what do we take away from this level of data, which is why I always put this slide on too, because this is from a 2010 study by Majid Ardis. It's a really interesting paper. I think it's probably in my must-read list for any musculoskeletal, but it's for a summary of back pain. And so we got a whole bunch of lines going on here, and these are the trajectories of treatment arms, placebo control arms, and passive arms, as in, so non-standard, what would be like a usual care arm. So they're all pooled together, and there's a pretty solid trend if we look across these 84 arms, right? So there's 57 trials included here, 84 arms, and this includes, I'm so sorry, I scrolled too much on my screen. I blew it, there we go. This includes both acute, subacute, and chronic. And so what I really like about that, to kind of follow up with your point there, Paul, is that we have people who are at 6 and 7 of pain, and they might still be at a 6.5 10 weeks in. That absolutely happens, right? We know that people who come in higher don't have great prognostics of getting a lot better, which is a really tricky, I find that really, really challenging. How do we, and that doesn't mean all people don't get better, and we'll kind of get into that in 2 slides. That point comes back to, but this, to kind of come back to that, if we look at acute presentation of low back pain, someone who's like, I treated my back last week, I'd like to reassure with kind of this prognostic data. Again, that patient or that person coming in is typically a lot less complicated than someone who's already been through the gambit a little bit, which is both definitely worthy to talk about. All right, who wants neck pain? What's prognostic outcomes of neck pain? Is it different?
My assumption is it's similar.
Good man. Very similar. So this is from the Hunt trial. I really like this slide a lot for two reasons. One, the similarities between neck and back pain to me is hilarious. I think this is a very similar trend in MSK research. But the thing I take away the most from this trial is this blue line up here is neck pain and low back pain. So we have a very small group of people with multi-site spine pain, and their prognosis does not look nearly as good. And the Hunt trial was just observing people. So this was minimal intervention, just tracking people. So this is where the next prognostic factor comes in, that multi-site pain domain. Yeah.
Do they look at also anxiety, depression, any of those things that are in here and break that out in any of these?
The Hunt trial's got a few papers that have kind of broken down through some secondary analysis stuff. They took a whole whack of measurements. Off the top of my head, I couldn't tell you the data on that, but the answer to that is there is many papers, subset papers off the Hunt trial. So yeah, there will be one that have looked at depressive and anxiety symptoms as well. Like we said, prognostic factor, it's a negative prognostic factor, right? It just is. That's a reality. But this is kind of getting back to your question a little bit in kind of before Paul, this next slide. So this is from a study by Voss in 2018. So this, or 2008, sorry. And this is looking at neck pain trajectories. And for the most part, we see that within 6 weeks, we have people who, we have 4% of people who are much improved. So this is a 7-point scale, 0 to 7. 6 out of 7 is much improved, 7 to 7 is fully recovered. So 6 out of 7 on the recovery scale. And at 6 weeks, we have close to about 65-66%. So 2/3 of people are feeling a lot better within 6 weeks of neck pain. And then by the end of the year, we get a little bit more improvement, but it's still that kind of 70%. And this is where we kind of see why that looks that way. So this ties in before. There is a group that comes in at 6.5, 7 that doesn't get better, right? That's interesting to me. That's that. So that's the person who comes in, we're 5 weeks into treatment, they're really frustrated, they don't know what's going on. You try to steer them in the right direction, because at that point, yeah, they might be part of this small subset, 20% of people that are not going to recover within that first year timeline. So I think that's relevant to know. I think it's both relevant to know that you have people who are going to do really well naturally without much intervention. And then you have people who are going to struggle, right? That's kind of where we like to say that art of being a clinician kind of ties in. So that's, again, spine pain similar, but again, acknowledging that there's definitely going to be some different trajectories between people there is relevant as well. Who wants to try this one? It's my favorite one, PFP. Anyone know prognostic outcomes on someone coming in with some general anterior knee pain? And this is my last pop quiz of the day. So from there's no more tests. There's no wrong answers to this one, I promise.
I'm going to say similar to low back pain and neck pain.
Good answer. Except there's no self-limiting prognostic nature to anterior knee pain. Fun fact. Now, there's a lot of caveats here. So yeah, this is definitely the trick. A lot of the research in PFP here is on adolescents. So Michael Rathliff's work is a lot of what we've seen. But in his study, it was 252 people with knee pain, 127 with PFP. And at the 2-year mark, 55 or 56% of people still had knee pain. Now, is that a measurement error issue where they felt better for a while and then got knee pain again when they were measured? I don't know. I can't answer that. But seemingly lots of people who start with knee pain still have knee pain that's impacting them, especially if we just try to kind of leave it alone. I find that really interesting, that PFP might be something that is, and this is just, might not be self-limiting. This is from the JOSPD guideline that Rich Willie was the first author on. So patellofemoral pain is not a self-limiting condition. Again, data is primarily from adolescents, not a ton of adult data. So take with that everything with a grain of salt. But I find that to be interesting and why it's a good idea. This is why I like a prognostic approach, right? So where I think that there's going to be people, and I've worked with people who I've given a very minimal approach with to neck and back pain, as in I've given someone with back pain nothing and said, check in with me in a week now that you're feeling okay. And they were fine. I did the same thing with neck pain the other day. I told a person that I think you just need to just keep chugging along. I think they're trending just fine. And they came back the next week and they said, yeah, I'm fine. Right. Like, but with knee pain, that might not be something that I do, because I might need to poke into this more and understand that there's a different approach to knee pain rather than general spinal pain. One final note, just because Geronimo hates qualitative literature, whenever I talk about knee pain, I really think everyone should read this qualitative study. I pulled a quote from it, which is like the classic, when you read qualitative study, people who've been living with persistent pain, like it's always very eye-opening, right? A quote is, I've missed out on things over the years, spending time with friends, spending time with family, and that kind of thing, because I've not been able to do it. And when we think of something like PFP, I think a lot of us are like, oh, I have an approach to PFP. Like I know how I would approach anterior knee pain and how we would get to things. And it's like, we still have, this coming out of people who have seen physiotherapists for their knee pain. It's just, again, humbling. So that is my kind of introduction of why I view prognostics as the first aspect of research to include into practice. So like when we look at taking research into practice, what's the one thing I think we can all take into our practice right away is knowing prognostics, knowing what we think general trends are, how that's going to change our approach. And that's part of informed consent. Person wants to know when's it's going to feel better. I like to give people the data, right? Person came in with neck pain. They had been experiencing it for a month. I was like, and they were trending a little bit better. They were starting to feel a little better. I just straight up told them, I said, okay, I think 2 to 4 weeks. I think you'll start feeling noticeably better within 2 to 4 weeks. Based on your other prognostic factors, based on the other things in your life right now, I think that is our timeline. How do you feel about that? They were pumped. About 4 weeks later, they were feeling better. So did I get lucky? Maybe. Very, very maybe. But that's why I kind of like that approach that way. Before I kind of touch on anything else, anyone thoughts, questions, ideas, concerns, experiences with themselves with this approach, not with this approach? Again, I'm very open to just kind of having a discussion or just keep rolling along.
I use a similar thing, but I don't typically give weeks, even though that's kind of what patients want, right? I kind of say, here's kind of the general time frame of healing of tissues, but pain doesn't necessarily equate to what's going on at the tissue, right? So the tissues will be ready for whatever we're going to be doing, but your pain experience is going to be slightly different. Right. And so what we're going to be trying to do is control for some of those things. But my job isn't always to make you zero pain. My job is to make you able to function and do the things that you want to do at an acceptable level of. Right. And then we kind of reframe that way. And that's where that's my entry point into it, because I don't necessarily know this person in 4 weeks they're going to get well, or in 6 weeks they're going to get well. But if I say that's general time frame of healing for things or whatever, and then we can go into that other discussion, that's where my integration of their social needs and their other things that's our talking point. Because if you've got all these other stressors and all these other things, I can't predict what your pain is going to do, but I can say that we're going to be able to load tissues and build you up within certain ways, right? And so that's where our target is.
Yeah, totally. And that's, again, sounds pretty much very, very similar to kind of how I view things and how I think that's, like you said, it's a really good entry point with people. A general timeline is it's reassurance, right? That's our first step to education and reassurance, right? Before I do prognosis kind of integrated with, again, in my clinical setting, we basically we have more tissue specific diagnoses as part of our clinical process. So I definitely tried to marry that with the prognosis kind of talk. I find that gets us, okay, here's what I think is kind of going on. Let's get away from that. Let's talk about what it actually looks like. We don't need to hyper focus on that. And the way that the analogy that I use all this when I'm speaking with other clinicians and other students and things is, I like this analogy of being a blackjack player, right? I think that knowing all the best things that we can is like counting cards. You can play blackjack without counting cards. You're going to lose more than you win, right? So I think by starting to pick these different things up that we conclude, now we're card counters at the table. We're starting to give ourselves an advantage to give people a better outlook on what we think is going on. It doesn't mean it's going to totally change our outcomes, but it gives us the best approach, I think.
But sometimes they're coming in as a dealer with 6 decks.
Absolutely, right? Like that's the thing too. Are they, is it single-handed and they're shuffling the 6 decks again? Like what's being stacked against us, right? It's a moving analogy for sure. And we just do our best, right? That's what it comes down to.
Go for it.
For
what about like prognostics factors for like knee or hip OA in regards to like, that's obviously the OA itself is not going away. So how do you explain that to a patient of like fluctuation in symptoms with a diagnosis that it's not something like low back pain where, you know, it's a little bit more, they may have a little bit more like thoughts about the osteoarthritis itself?
Yeah, I just do like the very, very classic motivational interviewing and just poke in, right? So I've had people come in with previous diagnoses of OA, with knee OA. I'm working with someone who has knee OA right now. And this is just like, what are your thoughts on it? What do you think knee OA is? What do you think it means? What have you been told? In terms of prognosis, like, again, I think we're very in like a supportive data saturated setting because of all the GLAD data that we have, right? Like we have hundred thousands of data points from GLAD data over the past 10 years for knee and hip OA. And I know Geronimo's jumping at the bit at this too, but like you can see the general trend that knee OA follows a pretty similar-ish recovery timeline on the group average. And the group average matters because people will do better overall, except for the people who end up going on to surgery. And we're fortunate, I think, in the domain for trying conservative care first and sending a knee OA because surgery is good. Like a TKA is a good surgery, right? Like 80% of people are resolution of symptoms. That's pretty, we're talking about probabilities. That's a pretty good probability of a good outcome. If we want to look at something like what GLAD does, I think Chris Barton posted an infographic a couple months ago where it was like 75% of people who started GLAD Australia didn't end up progressing to surgery, even though they were on a surgery list. So like those are the talking points I go to. I think that ties in kind of nicely with what Paul said before about pain being kind of a tough mark to always aim for. But do you need surgery is another good outcome that we can talk about, right? What is the prognosis like? What does surgery mean to you? Is that something that you've been told about, or do you actively not want surgery? As a chiropractor, people come to chiropractors because they don't want traditional medicine, whether I fully agree with that, but lots of people come in not wanting meds, not wanting surgery to me, right? That's just the natural kind of referral population that we get. And so I talk about what are the positive prognostics to feeling better with their knee OA, and talk about function, talk about what we can improve. And then I'd like to talk about, again, if you look at the GLAD data, 12 weeks of doing a couple, 6 weeks? So 2 times a week for 6 weeks, Geronimo? 12 visits over 6 weeks for GLAD. I'm not necessarily recommending that to everyone.
Yeah, it's 12 or 18.
I think it's 12. Not recommending that, but we can be like, yeah, people have, like it's that same kind of U-shaped, or that same kind of, I can draw it over here, right? That downwards trending. Same thing. I think we can see some improvement over the next few weeks trying to get active, how to control their aspects of your life. I don't think OA is altogether, I don't think symptomatic OA is altogether different than other conditions in the general area. I don't know if others feel totally different, but John was, again, I'm going to keep calling him up, but his favorite question is knee OA just PFP in people who are older?
I see it differently. I don't see it differently as far as what that term is, but I see it as arthrosis versus arthritis. Arthritis is an activated state of arthrosis, right? And we all have arthrosis as just part of our normal aging process, varies based off of your genetic predispositions and other factors, right? And I've seen people that I literally, when you're moving the joint, you can feel squaring off of the joint, and they're asymptomatic, right? And then I have other people that they've got a little wrinkle in their joint and they're fucking, they can't walk on it, right? So those things are completely different things, right? The pain experience with the level of arthrosis is completely different. And so you're always dealing with the individual. And my entry point there is, look, again, it's very similar. What is your understanding of this? What does this mean to you? Because unfortunately, people come to us after they've gone to a doctor, their friends, their cousins, their other stuff. And so there's a whole lot of preconceived notions that come in to the clinic with them, right? Before they typically are crossing at least my door, right? And so when they're coming across my door, there's a whole lot of stuff that we've got to unpack in their understanding of what this is. And so going back to some of that, okay, just because you have changes in your joint doesn't mean that you're going to have pain forever. It may, but it may not. here's the things. And even if it does, having range of motion and strength prior to the surgery is a great predictor of what your outcome is going to be. So let's go ahead and get after that, and then we'll see what we're going to do.
Yeah, totally. I think the one thing I think we're going to touch on is I think there's some GLAD data coming out on seeing if changes physical activity levels long term. So like, can introducing people to a physical activity program or approach actually impact behavior change for being more physically active later, which I think is important when we start talking about things like TKA, because we know from the data that people say they're going to be more active after TKA, but they end up not being more active after TKA, right? So can we, like, again, let's say GLAD, we put someone through or individual PT, group PT, whatever you want to call it. If that makes 20% of people more active, and even if that 20% goes on to TKA, that is going to have a better long-term effect on our TKA outcomes. Like, again, it's a very nice kind of approach to, again, ties in the probability aspects. How can we improve general outcomes over the time, right? That's my look to it, right? Again, that's kind of what this presentation was designed about, is like how little probabilities, little advantages, what can we add on, tack on, right? So then kind of leads into that. If anyone else, yeah, thank you for the discussion. Anyone else have any thoughts here before we kind of move on to some nitty gritty math, which is what everyone wants to do on a Saturday morning? That's what I thought, into the math. Okay, so why do I incessantly yell about probabilities? Because Gordon Guyatt tells me to, because he says I need to know effect sizes. And Gordon Guyatt is much smarter than I am. So I talk about effect sizes with everything, because I think effect sizes are what gives us the best understanding of a probability of getting someone better, especially in guiding our clinical reasoning. And I find that for me personally, like a year and a half ago, I could not tell you what an effect size was properly. I knew it existed, but I couldn't tell you what it meant. And that kind of was, I think, again, like January 2020 for me was when I was like, uh-oh, I have no idea what I'm reading. I love reading research, but I don't get it. And that kind of led me down this path. So I want to, if this is new for anyone, great. If it's not new, it's a good reminder, because sometimes you need to remember these definitions of things. But here is an example of an effect size of 0.8. So the most common effect size that we see in MSK literature is going to be Cohen's D. It's a statistic that we're not going to actually get into the math for. Basically, all you need to know is that it compares the group means, so those mean scores, and it's divided by the combined standard deviation across the groups. So we're trying to have an understanding of what is a better effect, and then by doing so, we kind of control for the variance within the fluctuation of scores of people. But the reason I want to talk about this is because if we have a large effect size, so Cohen's D of 0.8 is what the boundary for large is often considered. It's kind of arbitrary. But what that means and what we should care about is this number down here. So this probability of superiority. So with a Cohen's D of 8, there is a 71.4% chance that if we plucked a person out of that treatment group versus the control group, 71% of the chance, or 71% of the time, we're going to pluck someone out of the treatment group that has a better outcome than the control group. That helps us with our probabilities. So in this sense, if we're comparing two treatments, and it doesn't really matter what the treatments are, it doesn't matter what your preference for treatments are. But if we have treatment A versus treatment B, and treatment A across the literature consistently shows a better effect size that way, we know that if those are our two best options, 71% of the time, I'm going to get a better outcome than the other group.
I have a question based off that.
Yeah.
How are they defining better outcome? Is it like any outcomes better? Is it like MCI or like minimally clinically important difference, or what?
Yeah, so it's going to be, for this, it's going to be literally just the mean raw group scores. And then you can kind of see if that difference is clinically meaningful. That's important too, don't get me wrong, right? And that really becomes important if treatment A is 24 visits and treatment B is 6, right? And you're getting like, you might be getting a decent effect size, but there's no way you could ever actually implement that 24 session program. If there's insurance barriers, if there's financial barriers, if you're cash, like whatever reason that could be, that's again a worthy consideration. And I kind of, we'll touch on that after for trying to integrate that. But this would be like, for example, let's say we're looking at tendinopathy and we're looking at the Visa A score. Like this would be that there's a 71.4% chance that group treatment A is going to have a better outcome on the Visa A than on treatment B across the group means. So, and I'll also talk about why group means are a perfectly good number to work on, because that gets criticized a lot. And I think that's a worthy discussion, right? People are like, oh, people aren't the average. People are individuals. They certainly are individuals. But on average, people behave like the average more than they do like outliers. So that's a worthy fact. But so Cohen's D of 0.8, and then the other interesting statistic is this Cohen's U3. So 78.8% of the treatment group will be above the mean of the control group. So that's, again, just something worth knowing, that most people in that treatment group will have done better than the other group on average. When we get into something that's like a smaller effect size, like 0.3, you can see how drastically those numbers drop, though, right? So now we only have a probability of superiority of 58.4%, which is a small advantage, but not a big one.
So how is the number needed to treat correlated with these?
Yeah, so number needed to treat is, I think, helpful to me, but it's, if you talk to medical statisticians, they actually hate it, right? So like, which is, I think, funny. I'm not smart. I'm nearly as smart as any of them. But if we look back, so number needed to treat of 3.53. So NNT just means that I need to treat 3.5 people, whatever 3.5 people is, to get one better outcome, right? So that means for every 3.5 people I treat, I get one better outcome than I would if I were to use the other treatment. That's why it's kind of a messy kind of thing, right? And again, that ties in nicely. We see studies that have like a number needed to treat of 8. And you're like, okay, so I need to treat 8 people to get one more better outcome. But again, if that treatment is 24 people, 24 sessions, I'm like, okay, so now I have to do 8 by 24. Now I'm looking at, what is this? 400 sessions to get a better outcome for a person. And that's really tricky in the current healthcare setting. Both, again, I'm in Canada. That's really tricky for us up here. You guys down there, I know it's not easier. So, right. And so again, if we look at, and that's a great question, we look at this Cohen's D of 0.3, and 0.3 is a small effect size. And that is the most common effect size range that we see in MSK. 0.3 to 0.4, that is most of the time what you see. We're chasing really small advantages. So that number needed to treat bumps way up again. So 10.6 now, right? So you're treating a lot more people with this treatment in order to get one more success.
Right. And if it's correlated, my point here is the number needed to treat. Clinicians oftentimes feel like they're losing a battle, right?
Yeah.
I suck, especially if they're early in their career and I'm really not good. But if our average Cohen's D is 0.3, that tells you that you're going to be seeing 11 people, right, utilizing the standard of care that's here before you see one person get well.
One more person get well.
Right,
so
one more person get well.
Yeah.
Right. So based off of these differences, that's part of why we're not seeing these. Oh, I'm great, and you're not always feeling I'm great on some of these things, because many of our effect sizes are fairly small. Right. And you've got to see a large number of people before you see significant relative differences when you change your practice pattern, especially if it's based off of one article that's not necessarily right. I mean, so some of this is this confusion with a lot of different things. And I just want younger clinicians to know you got to keep working this and keep doing this, and you'll see some variances based off of how you're applying some of this. But most of our effect sizes are pretty damn small.
Absolutely. Yeah, like again, it seems, I think it's really daunting, especially right for young clinicians, myself obviously included. I like to zoom out though, right? Like even if I have a number needed to treat of 10, right? Let's say I see 100 NEOA patients. Let's say that, right? Like if I'm using the best standard of care, I have an effect size of 0.3. To me, that's 10 better outcomes. That's 10 people who feel better than they would have otherwise, right? So individual level, it's really daunting. Macro level, take a step back, right? That's 10 people with
right.
PFT.
To my point, you've got to keep working it and get to these larger numbers, so you're actually having these grander effect sizes. So I mean, you know, these other things.
Yeah. Oh, like you said, yeah, it's a battle of probabilities, and probabilities take time to average out, right? You need samples to make this all add up. So that's why I think it's really important. I have a couple of just slides on some results from meta-analysis just to highlight that. So this one's just comparing, this is an elbow tendinopathy paper. It's comparing exercise to weight and see. Very humble effect sizes for exercise over weight and see. And again, to go back to Chris, you made a good point, like what's MID here? So, or minimal MCID, MIC, whatever we're calling it these days, it changes every 2 weeks. Right? Like we're only seeing, again, for this, even this 0.3, we're only seeing a change score of 6 points on the pain scale, right? That's not a ton, especially if you look at something like exercise, like daunting exercise programs versus wait and see, right? That's not overly convincing to make someone do a lot of stuff to make a huge difference. Now it's a little bit of a difference. And if someone's willing to work at it, they're going to have a little bit of a difference, right? But it's humbling as well. So that's why I think that's valuable to understand that both. So SMD, standardized mean difference, is often equivocal to Cohen's D. So a small effect size, very humble differences. If we look at something, again, elbow tendinopathy, same paper, this now is exercise versus corticosteroids. We can be a little bit happier with these numbers, I think. Now we're like, okay. Again, now we're reaching like, again, even this nice 0.7 is a pretty big effect size. But this is almost kind of like an 18 out of 100 point difference. That's typically past the traditional, whatever, 20% MIC threshold you want to use, 1.8 point, 1.4 point threshold you want to use. So now we have a larger effect size, and what that translates is we might start to see that clinical difference, right? So again, this is not a pro exercise over corticosteroid talk. It's just a representation. So sometimes corticosteroids are very good, lots of conditions actually. One thing I'd like to just reinforce again with reading forest plots, because if you want to call meta-analyses the hierarchy of evidence, it's important to just kind of be familiar with what we're looking at. So again, understanding that standardized mean difference and our pooled standardized mean differences paper topics don't really matter. It's exercise therapy plus manual therapy versus just exercise for neck pain. So very small, if not, realizable differences across the board. But the one thing I always say about meta-analyses too is I like to read the biggest sample size paper from a meta-analysis, just to see what happened there. That's if I'm gonna look at a new meta-analysis, I want to see what their big papers are from it, because I think if we have a large sample size and a well-structured study, that can tell us a lot versus maybe not the 15-person RCT doesn't quite tell us the same amount. And so I have a few things always highlighted on this slide. So something to be aware of is, again, just heterogeneity within a study. So the reason this is so low is because all these confidence intervals are overlapping. So that's how we know that our results are pretty similar. Geronimo and I just ran a meta-analysis on Thursday, and we got 100% heterogeneity. So we had fun wondering what went on there. But for us, just for whatever it's worth, we had very small standard deviations. And as such, our confidence intervals didn't really overlap a ton, gave us a lot of heterogeneity because there was variance within the results. But again, really low heterogeneity says that there's a pretty similar trend amongst things for that confidence interval. I think it's worthy to note. And then I touched on it before, but understand how things are being weighted. And this is an example where I think, Geronimo, this would be a study that used fixed effects, because this is weighted proportional to sample size.
No, it's random effects. Look, it says random right there.
Does it
have 0% heterogeneity.
Oh yeah, true. So it would match fixed effects because it has 0% heterogeneity. See, this is why we bring you on. This is a stats discussion.
Yeah, dude, I'm a stats guy.
Big guy, yeah. Right. So yeah, this is, again, because it's low heterogeneity, we end up with the large sample size studies have the most weighting. So again, that's why I like to pull those out and read them. I think they're interesting. I think this is a good place to start with meta-analysis. I kind of want to just zoom through the next stuff, because again, this is kind of cut and dry. These are my yellow flags for reading papers. So does your patient match inclusion criteria? I hope everyone has heard that one. Can we make sure we're reading papers about the right demographics? It's pretty important. This is the one these are the two that I talk about a lot with people, other students, young clinicians, is you can read a great paper and have great results. The methods are clear, but can you even implement the intervention in your setting, right? So my example that I always give is so there's those great Lift More trials for osteoporosis that shows really great results for people, including increasing bone mass density with barbell training. I do not have a barbell in my clinic right now. So I have people with osteoporosis who I want to work with to help them get their bone mass density up, but I don't, that trial is essentially meaningless to me right now. It tells me that exercise is probably safe, but the protocol used for it and the intervention used for it doesn't help me, right? So we can fall in love with a lot of papers really easily and try to bring them into practice, but if they're not feasible to implement, that's really hard. And then on top of that, are you comfortable? So I've read a lot about ACL recovery literature. So ACL reconstruction literature, it's something that I'm really interested in. I'd love to see the progression of programs. But again, I'm a chiropractic student, I'm a chiropractor. I'm not going to see a lot of ACL reconstruction, and I'm not going to really see it in my training. So I'm not super comfortable if someone came in and said, hey, I'm going to have ACL surgery. Can you help me through the recovery? I'd be like, I've never seen, I don't have the equipment. I don't have the confidence. I don't have the settings. So I think that's a really humbling and important point too, right? So I can read every paper by Lynn Snyder Mackler and it won't help me because I'm not going to see a lot of ACLs. So just again, train of thought for saving time, because people often ask me, what paper should I be reading? They're like, oh, should I read this paper? It's like, does it even make sense to you? Does it make sense to you to spend the time dissecting it, analyzing it, appraising it? Like, we only have so much time in the day. Conversely, big red flag paper guy. And the one I'm going to focus on really is just sample size. I mentioned it before, but it's my passion project to talk about why sample size matters. The other things, like making sure that, again, intervention controls, we talked about, like, is the intervention 24 versus 6 treatments? Is contact time explaining things? Is burden of exercise time explaining differences? That's important. And then if you want to be really fancy, read pre-registrations of trials of RCTs. Watch out for outcome switching, right? If the trial registration says their number one outcome is the NDI, and then you read the paper and their number one outcome is the GROC, there's a recycling bin for that paper, right? You don't need that. But I do want to talk about sample size, because if people have heard this before, good reinforcement. If you haven't, this is something that really opened my eyes. So a while ago, 6 months ago, I ran some code. I ran 10,000 simulations of simulation data. So of artificial trial of an effect size of 0.3. So I ran 10,000 simulations with basically various sample size, right? So statistical power is, don't need to get into that aside from the fact that it can be kind of represented to appropriate sample size for the analysis that you're running. So this chart is the plotting of the average effect size of every simulation that came up statistically significant. So anything, I set my alpha value at 0.05, so anything below a p-value of 0.05 very commonly. And when you have a very small sample size, which led to a small statistical power of this analysis, you can see that the average significant effect size is 1.25, or almost 5 times or 4 times above what the true effect size was, because I set the true effect size. And so you can see that as we appropriately have enough people to detect that smaller effect size, we increase our sample size, we're able to adequately get results. You can see that on average, those effect sizes get closer and closer to that true effect of 0.3. So that's something to be aware of when we're reading trials that are small sample size. And again, you read a trial that's 2 groups, n equals 20 in both groups, and there's an effect size of 1.0, and I'm like, holy hell, what do I need to start implementing tomorrow to get these effects? And I'm like, maybe I should hold off. Maybe we should just, we should not jump the gun to reevaluate, to implement that, only because that might be happening, right? So when we have underpowered analyses that report statistically significant results, the effect size is often inflated. And then one thing that's important to note also is that a lot of trials that don't have enough sample size or are underpowered for their analysis will often have like just a negative result, because there's just not enough people to detect the actual effect. So in general, sample size really, really, really dictates what our effect size and what we can confidently say. And that's why meta-analyses was created originally, to try to pool those and give us a better understanding. And to a certain degree, it does. It doesn't always do that, because not every meta-analysis is perfect, but this is something I find very interesting just to be aware of. Keep your red flag guys going. And then kind of the last few things is that this is from going back to the Gordon Guide article. This is really important. Just being a good secondary source appraiser, right? Like, it's really hard to read every new RCT that comes out. It's really hard to carve out time in your life to do that. Thankfully, hopefully, we have groups that are able to summarize evidence well. They're not always made the same. There's lots of politics involved in clinical practice guidelines, depending on what the investment groups are. So I love this paper by Ivan Lin and a bunch of other very smart people. Because if we look at kind of the assessment of clinical practice guidelines for low back pain, not great across the board. lots of low quality stuff. I always often reference back to the nice low back pain guidelines. The reason is very literally largely influenced by this paper, right? Decent scores across the board. There's lots of guidelines out there. I kind of know where I want to start. So if I'm going to be a secondary source consumer, which I am, definitely start with, whenever I'm looking at conditions, I definitely try to find clinical practice guidelines and kind of work backwards from there. Same thing kind of goes with osteoarthritis. Not all guidelines are built the same. We have lots of low score guidelines, but funny enough, the nice guidelines did very well here again. But the American Academy of Orthopedic Surgeons has a nice guideline as well. And then you can always go with kind of like the ULAR group is pretty good as well. So I like to just touch on that. And then my last slide, and I promise.
And hold on for just a second. When you're doing that consumerism, how much of it do you base off of? Because I look at some of the people that they put onto the committees to put some of these together. Mm-hmm. And you know that certain people have a train of thought, that's their literature bias, that's everything they are. So if you're a reader of the literature, you can look and go, okay, I got to look out for this, right?
Yeah.
And like the APTAs, many of them get kind of put in that low to medium, mm-hmm. right? But if you got rid of all the C and lower level stuff, because they have C, D, E, F, right? And pull out a lot of the stuff where a lot of guys are like, yeah, but if I'm on this panel, we're going to include my thought process. So that goes under the F type bullshit, right? If we did that and just stayed with the A's and B's, I wonder what that would rate, right? So there are some ways to self-edit within like in the APTA's guidelines or some of these other guidelines and look and go, okay, yeah, this is so-and-so's bias, throw that shit out. Because I already know that guy writes that way, right? I mean,
no, it's funny. It's funny you say that. I was using a JOSPT guideline for part of another presentation, and that's what I highlighted. Is like there's a lot of C's and D's here, guys. A lot of C's and D's. Maybe stick to the old B's, B's and A's, right? And I think that's actually a really nice component of those JOSPT guidelines. I think they actually do a very nice job of summarizing evidence results.
That's what I like about them is they grade it and they tell you this is shit, but we're including it because it's some of the guys on the papers, basically. I mean, that's really what I read it as, right? I mean, if you're some of this lower level shit, it really is just these guys, this is their bent. And if I'm going to sit on this panel, you're going to include my thought process, but we're going to at least grade it an F.
Yeah. The nice thing, and I can really only speak really clearly on kind of the nice guidelines for the low back pain, but what's really interesting is you can see the full transparent process. If you go on the NICE website and look at those low back pain guidelines, you can see every one of their systematic review questions. They ran, I think, 26 systematic reviews to make their guideline. Over 700 studies, I believe, are included into it, right? Like if a project takes 4 years and 26 systematic reviews, I think we're starting to kind of put together a little more consistency. Right. And it's a very cautious guideline as well.
Right. And we can always argue inclusion of 700 articles, right? Mm-hmm. I mean, are there really 700 good articles?
Oh, no, there are not. There certainly are not. And that's something that I always love to say, I love to say from my naive point of view is, you know, can I look at 30 articles that summarize things, or can I read the 3 highest quality ones and get a better understanding of what that's going to be? I think it ties back nicely, right? Like how many N equals 30 studies do you need to read with your time, right? They might be interesting. And don't get me wrong, there's definitely conditions where there's not that many people, very low incidence, very low prevalence. And so it's really hard to research those. And oh my gosh.
Well, research in general is hard. I never try to slam research because it's just hard in general. Most of it sucks, honestly, but it's because it's so hard to do, right? Yeah. And so that makes it even harder as a clinician is how do we apply? This is why I love this kind of a discussion. How do we actually apply the literature and what are our cheat codes to try to make the best use of time with the amount of literature that's being produced? Even though much of it is shit, how do we identify shit so we don't even spend our time on it? And then how do we move forward with what is there that's halfway decent and make the best use of our time so that we can help more people? And that's what these discussions need to be happening more often. And that's what I love about this.
Yeah, totally. And that's why this topic is like a passion project of mine as well, is again, so I've been fortunate to be involved with a little bit of original research, some review research, and the original research was so humbling, right? Like so humbling. I was like, I came in guns blazing to it. I was like, I'm going to do this great job. And I got halfway through and they said, I am staying afloat. I'm doing my best. I'm going to try to make this the best project that can then progress things forward. But again, it is
when you
like,
actually have to try to do something that you judge from afar and go, man, these people suck. And then when you actually are in it and you see the limitations and the practical problems, you're like, holy shit, okay. I give people grace, right? They're the man in the arena, and I'm going to give them a little grace for being in the arena, and we're going to go from there.
Absolutely, right? And so that's where I see it too. I think that if everyone can get involved with any kind of level of research project, I think there's some requirements for some of the DPT stuff. We don't have a requirement for us anymore at CMCC. I think the masters of PTs in Canada, the varying degree of thesis work is different as well. But again, I think it's a very humbling and worthy kind of experience to get involved with. But then my final slide, kind of the day, this was inspired a few weeks ago. Someone made a comment of, and it's a valid comment, like, can we ever be evidence-based if our people never fit the demographics of a randomized control trial? I think that's a really interesting point, right? Like, you're never going to find your individual people you talk to will never perfectly fit in boxes because they're people and they all have experiences. I think there is an infinite amount of subgroups if you want to do it, right? How many people on earth do we have? There's that many subgroups if you really want to do it that way. So I think what we kind of look at is, I really like this paper from Neil O'Connell and Steve Camper, and pardon the other two authors who I don't actually know. But this looks at the distribution of results across studies of spinal pain. And so what they're trying to say is, if you actually look, people kind of have this one's a little kind of iffy, but on average, people kind of hold a similar response pattern. So most people kind of respond-ish the same. So this is for acute care for spine pain, and here's chronic, but you can kind of see the same thing. We have a lot more people who respond similarly than we do have we don't have like a bimodal distribution. We don't have a ton of people on the left and a ton of people on the right. Most people kind of respond similarly on average, right? Which is, I think, a really interesting point. Is that's when we just go back to taking the best thing that we have at our disposal and tailoring it to the person, right? It's kind of an interesting topic, I find. And I like the phrase, most people are more average than we give them credit for.
I don't disagree, but I do think that I use literature much more to help me rule out where my entry points are, right, than to rule in what it is. They give me a starting place potentially to explain to somebody, here's some options, and this is where the literature kind of tells me we're better off. But I don't know their circumstances. I don't know all these other kind of things, and they're going to have to bring that into the world, right? Because they're the experts in their life and their experience. I'm the expert hopefully the expert in the literature and what I'm bringing to the table. And we're trying to bring our expertise to this problem, right?
Absolutely.
And that's the reality of what we should be doing. And the literature gives us a starting point for talking to these individuals, but I'm not sure I can always go, yeah, this means this for you. I really don't know that I know that. Right. Yeah. And I don't think we ever will. And I think that certainty is what some younger people are looking for, but that certainty is never going to be there. Yeah. What you think works today, you'll find in the literature 20 years from now is going to be shit. Right. I mean, I just hate to tell you that, but that's kind of the reality. So don't link to that. Know that these are barriers. They're kind of like, the bowling guidelines where they keep you going down the thing to hit some pins. But that individual pin that you're trying to hit, when you're bouncing it through these guidelines, it's kind of hard, right? And so it very much is kind of that thing. And so it's learning how to apply. And that's why I think these discussions are very, very important. How do we apply literature to the person in front of us?
Totally, right? And that's kind of where I think this kind of wraps up and closes nicely, is that, yeah, you're really working towards what makes sense in the moment. Like you said, I like to rule things out. When I present shared decision making, I say these are the best things. These give us the best options. Which one makes sense to you? What are you interested in trying? Right? Because at the end of the day, we're here to support people. And we all have biases. That's an unavoidable concept, but you try your best to minimize them and make sense to the person in front of you, right? So it's tricky. I also I have a few case studies. I'm not even no point to kind of go through them, because again, we've kind of covered a lot of different stuff here, and I don't want to keep people too long here. So I'm gonna stop my share and see if anyone kind of has any final closing thoughts here or any other discussion. And thank you, Paul, for everything that you brought up today. I think this is, again, it's a really hard subject, and research application and appraisal is really challenging and time consuming, right? So my golden ticket is always kind of know your prognostics, have an understanding of what consensus is across some of the higher quality guidelines. If you can do those, you're doing really well, honestly. And then, be communicate and be empathetic. All those things.
I'd like to know, of those still on the call, when I read the paper, it was interesting. They didn't say we want to diagnose based off of the literature. That was kind of like, we're going to be good at diagnosis, and then we want to treat well based off of the literature and all that stuff. But we know some of our diagnostics suck as well. All right. So how many people feel comfortable with the diagnostics, or should we also be looking very, very specifically at the diagnostics? Because how well can we actually diagnose? Okay, yeah, this is your supraspinatus tendon that you got a problem with, and all that kind of shit. Anybody?
What was the question, Paul?
So the paper by Tekin and Guy talk a lot about like the EBM model and shared decision making for treatment. But in the world of medicine, diagnostics is so different. So we have the luxury of also our diagnostic tools not being good. So we have the luxury of our treatments being, having diverse abilities and opportunities, but we also have that issue extends to diagnosis for us as well, which is, why make things easy, right? So how do you I think I'll go first here. I think it does extend to diagnosis. I had this discussion with someone yesterday. They were dealing with someone. They were like, I think tests are kind of pointing at it pretty plantar fasciitis-y. The person says, oh, I really hope it's not plantar fasciitis. Do I explain to them that they just have plantar heel pain, which is actually the broad term we're using for plantar fasciitis now? Does that label, which still says the same thing for my prognosis and my treatment, but does this label more friendly to a person? The answer to that is there's so many, at least from my perspective, there's so many layers to that, right? I'm okay personally, and I typically give kind of a general diagnosis and shift the discussion to prognosis, kind of as I talked about early on. Most people I've worked with so far, only a couple have been very focused on specific diagnosis. Meet people where they're at on that is always my recommendation. I don't know if you feel the same way, right? If someone is really high, they come in with a diagnosis, just again, what does that mean to you? Why are you focused on it? What if it wasn't that, what would that mean to you? That's always just my approach.
Go ahead, Chris.
Ben, I'm just curious, in the setting you're in, I'm assuming you have an overseeing clinician.
Mm-hmm.
What's their reaction to maybe you being a little bit more conservative with the volume of treatment, or what you're saying to patients, or even patients' perceptions of coming into chiro? Because I know you said you're close to the PT clinic as well. Has that been an uphill battle?
So first thing, my supervising clinician is awesome. I've been really, really fortunate. We've had a lot of really good discussions, and he pushes at me and I'll push back. We have disagreements, but that's a natural process of talking to anyone in the field, right? You're never going to fully agree with anyone on everything, right? But we have really great discussions. What we have to do we're now evaluated on my end on clinical competency. And so my clinician's done I think he's done a great job taking that to heart. So he is if you're doing what is competent and valuable care, go for it, right? I had a patient who had been at initial follow-up discharge done, which again, historically, that might have not necessarily been something that always happens in acute chiropractic settings. Again, there's obviously, you can look at the data yourselves on how much treatment typically comes from chiropractic care. It's often, we get told 3 times a week for 3 weeks for most conditions, right? Which I think is maybe a little over treatment in my opinion. So I've been fortunate that way. In terms of working beside a PT clinic when I'm kind of operating out of a single room, that's been a challenge for me for sure. Especially since I come from a strength conditioning background where I've worked with people in big open gym settings. And as a S&C, you're always working with people who have aches and pains, right? So while you're not exclusively treating those, you're still working within those paradigms. So I've been fortunate to have that background for a long time of kind of adjusting exercise programs and training things through people with pain already. But that's been hard, totally. they have a really nice setup for an inpatient hospital PT. Like they have a sweet setup. Like I wish I could use it. I just look at it and then go into my room and not use it.
What's your goal? Like, what do you want to do once you graduate? Do you want to go into research? Do you want to work in a clinic or both?
Yeah, so I'm applying into master's programs for next year, but I'm fully intending on trying to work part-time. So part-time for the master's. My goal is PhD. So my specific area of research that I'm, again, methods and health research methods is really interesting, but the thing I'm kind of most passionate about is actually healthy aging. So a lot of the stuff that I read and I've done is with older adults. And so that's what, so I'm a big advocate for appropriate assessment of older adults when they come in for whatever health condition, right? So I'm a big assess for your sarcopenia on every single person over the age of 60. Takes 2 seconds.
Close to my age grouping, can you find an article or some level of where bourbon helps improve?
Look, as an evidence-informed clinician, I can tell you that from my personal experience and your personal preferences, that bourbon is just fine.
Perfect. So, that's what I want to know.
I mean, yeah, if you want to make the 3 pillars argument, like we got 2 pillars going for us right here, so I think you're fine. But yeah, Chris, my goals are, I hope to still be practicing and doing research together. I think there's an unfortunate disconnect sometimes where clinicians can occasionally view researchers as not being, in the trenches in the field as part of that. And I think you can definitely have some validity to that. But I also think, again, people that are in a clinical trial are people in pain too. So I think sometimes conversely on the clinician side of things, we think that the people that are in studies aren't people too. But when you start looking at those bigger studies where they take a ton of baseline demographics, boy, do you realize people are complicated, right? And I think there's beauty in that too. So that's my goal. It's really tricky in full transparency. Again, to give you guys some background on what chiropractic looks like in Ontario, where I live, people will either pay cash or they have often workplace benefits. So their benefits are supported through their employers. Most people in chiropractic have $500 a year, and $500 is, so we get paid on treatment time, there's no billing codes. That's not what we deal with. We deal with treatment time. But for a lot of people, that $500 isn't even full coverage. So they're still paying a deductible or a copay along with that every time. So it's a bit of a saturated market. And I think it's really hard, especially again, like I mentioned ACL recovery. Like if I was working with someone with an ACL recovery and they were out of their, I think with surgery, you get like 6 PT visits or whatever, right? ACLR is a long process. 6 isn't going to cut it probably unless you have a lot of other stuff going on. Right. But if they're seeing me for $60 a pop, $70 with 5 more sessions, 6 more sessions, right? Like that's where I really have a really hard time with it. And I think that's something I know reimbursement's different. And I can only speak from my experience up here. That's my number one biggest complaint is I really struggle with the financial side of the profession. And that's the biggest hurdle that I'm going to see myself moving forward through.
I would say that you're well suited for that, though, with your strength and conditioning background, because at a certain point, they're outside of an acute nature, and then you're just trying to get them strong and back to the task analysis, whatever that sport or activity may be. And so that's where you're actually probably fairly well set within that and can charge based off of whatever the cash rate is that's appropriate for that, right?
Right. That's again, like in a perfect setting, it's how do you make that make sense? Like I work as an SNC in like an integrated clinic where they do a lot of, okay, I think you're good for clinical care. You're interested in doing group training, personal training, right? I think those models are really interesting in terms of making ethical healthcare and ethical support make sense. The biggest challenge is that it's kind of, as a chiropractor, as the title and the label it's associated with it, if a lot of clinics you approach, I'm going to crack spines and put needles in you. That's the 2 things. And
rack and crack them, and let's do the 40 or 60 or 70 of those a day, and let's go.
Right, exactly. And I obviously, you guys heard my presentation. You've heard that I should discharge someone after 2 visits. I am recently, like, that is my approach, and that doesn't always align with kind of business models that exist. But again, I don't think that's completely foreign. I think in PT in the US, you all experience something similar with some of the chain businesses that might also have like high demand expectations. I don't know if you all talk about dollar patient value. That's something discussed in my world a lot. How many dollars can you get out of each patient? Which sounds bad.
Well, I mean, it's typically considered, we don't call it dollar patient type stuff. It's basically what's the lifetime value of the patient.
Right.
Right. And so you're trying to create a lifetime patient, somebody who's going to come back if they have any other future aspects, right? All those kind of things. And so it's aligning that to where you are their therapist for the rest of their life, because you don't want to be physical therapy. You want to be, that's my therapist. That's a different mindset and how you approach the client delivery and the care delivery, right? Because you're trying to make sure that you're their friends, you're their confidant, you're their person they're going to come to for the future. And that increases their lifetime value to your business, right? So it is that kind of thing. And there is that thought process and that model that's there. Now there's other models, again, the big change, anything that's a peg related, right? Is, yeah,
exactly. Derek.
Yeah, right, Derek. Exactly. 2 times a week forever.
Right. That's, yeah. It's like, that's where I think I think that's a great point again, Paul, right? Like I'm more than happy to work with someone until they're comfortable. And then again, hey, something else comes up, you know where I am, right? You know, I'm not going to overtreat you into the ground. You know, I'm not making you come in 3 times a week because I don't think that's necessary. That's how I see my model moving forward, but exactly the same thing, right? Like if, especially with, again, the way life works, people get hurt, stuff happens, right? Like that's life. So trying to find a way that makes sense. So that's my kind of synopsis on that.
Right, but I think with the strength and conditioning, that's an add-on piece that others aren't going to necessarily have per se within that, right? And I think that's a separator. And from my PT friends in the Canadian market, it's not much different as far. I think they might get $1,000, so it's really not that much different.
yeah, they get an extra 500 though. Those guys figured out they have half the schooling and twice the insurance money.
Right. So they get a little bit more, but it's still, can you? And again, I hate to say this, but it's a sales game. Mm-hmm. Every time, and I don't mean that as a negative, because when we're presenting what the literature is, it's still a sales game because you want to use the best evidence. They may think that taping in a needle and standing on their head and spinning 3 times is what cures them, right? Because that's what worked before. How are we going to have that discussion, right? So it's still part of, it's always a sales presentation. And then how do you bring yourself into the forefront so that your specific skill sets show what the value is to that individual, so they want to come seek those skill sets in the future, because people aren't going to have issues in the future. You just want to be the person that they want to come see.
Totally. Yeah, that's the thing, right? And that's why it's about, again, like I try to always make this caveat too, especially when I talk about best evidence for interventions, is that I'm not opposed to any intervention, using any intervention that makes sense for the person at the right time with the right support literature. Like there's, as much as I like to poke fun at certain things, there's, when things are indicated and things make sense, they make sense, right? So,
and the reality is if somebody said that ultrasound after 2 sessions made them feel 100% better, you're an idiot not to try to do that. You can still add your exercise. You can still add to that. It's okay. We're going to do 6 minutes instead of 15 or 20 or whatever they may have had. They do not know. All they know is they got what they needed. And if that makes them feel better, because belief is a huge part of any of this, right? Mm-hmm. You're an idiot, even if you don't have any belief in that. You don't even have to turn the fucking machine on. I don't care. The belief is what's going to drive that. And then you can get to your other shit, right? But if you're not doing that and their belief isn't there, they're not going to get well. And I don't care how good the rest of your skill set is.
Right.
Because they're not believing that they're getting what they need. Mm-hmm. And that belief is huge.
Yeah, totally. And again, like one of the cases I had from this presentation was someone who came in with some neck pain, and they had like they had neck pain before. Their previous treatment was exercises and manual therapy. And I was like, there's solid research that'll help do the trick. That was their expectation. It's, again, no brainer, right? Like they didn't come in asking for 8 things I did not want to do. They came in asking for things that, I think this is supported. I think this is a reasonable approach, and you want it. Wow, call it a day. No arguments for me. I don't need to sit there and lecture the non-specific effects of manual therapy. Like I don't need to do that, right? He's fine with it. We got him moving. Okay.
I ran a test recently on an individual motor vehicle accident. His truck was flipped over by the wind, right? Neck issues, yeah. I mean, empty truck and it's a sale, right? So it literally flipped over while he was moving, right? So we're doing all this stuff and he kept saying, my neck feels like it just needs to pop. And I'm trying to just do exercise, trying to do all this stuff, but he is insistent that it needs to pop. One little manip, and all of a sudden he comes back and I'm 100% cured. Everything's great. And it was his belief in that shit didn't do shit as far as fixing anything, but his belief that once we got it popped, everything's perfect.
Yeah.
And he was done with the clinic, right? He's 100% full joy. All right. If we're not meeting them where they are, then we're not doing a service to that patient.
Right. And that's, I totally agree. And that's why, again, I like going back to those probabilities. If an intervention is not going to reduce the probability of a positive outcome, then that gives you, a different lens for it versus like, if we know, oh, doing this actually seems to make people worse. Like, for example, I think for whiplash, there's like strengths, counter strengths, like PNF work on the neck is actually not recommended because it's made people worse in the past, which makes sense. Like really straining from a whiplash injury doesn't add up, right? So if someone's like, oh, I've done that before, I think that'll help. That might be the time where you're like, actually, I think that could make things worse. Maybe let's try something a little milder, different, right? But otherwise, yeah, I'm very much of the belief, and that's been a personal, again, caveat and growing point for myself is do the best by the patient, right? And include the research that makes the best sense, implement it. And, there's things with small benefits for someone with big beliefs that might maximize those small benefits, right?
From a, like I'm thinking a lot of students in my class who are like on rotations now, and they like, I've talked to a lot of them and they're just like stuck with trying to explain some of these like prognostic indicators to patients because they just like, they aren't well read, and they're realizing that now, trying to like talk to patients about it. Do you have like, what would your recommendation be to like a student that's just like, they're not in this kind of like realm of kind of feeling comfortable navigating research? Would you recommend like, hey, go directly to a CPG and like, this is where you'd find good like heuristics of prognostics? Or are there any websites or something where you're like, oh, this is a good list of it? Because I feel like it's not in a centralized database.
That's a great point for prognostic data. That's an absolutely excellent question. So the two things that I always start with for a new condition, like for example, I've had a couple of cases of patients with carpal tunnel syndrome, and full transparency, going through my undergrad education, we talked about carpal tunnel syndrome, but I didn't really, it's got a relatively low prevalence in the world. Most cases are mild. It's mainly handled by surgeons, right? Like it's not to say that we don't have. So the first thing that I did to start with that is I looked at just natural history clinical course, no treatment. What does that look like for people? That's the first place I start with. If I tell this person to go home, they'll put some ice on it over the next few weeks and they'll feel better, that's like what I want to know. Will that work? Turns out clinical course of carpal tunnel is not that great when you don't intervene. So it's not self-limiting. Okay, that's step one for me. Am I working with a condition? I hope this answers, but am I working for a condition that's self-limiting? So first step, look for prognostic or natural history search. If you just, again, the beautiful thing about prognostic research and just natural history research is it's super not complicated. They get a bunch of people who have a condition, take baseline readings, take follow-ups, record if they're being treated or not. And it kind of paints you a pretty good picture of what's going on. So that's my first recommendation, is try to see what self-limiting is, what natural history is. I don't think you need to do a ton of vetting of a lot of that research because they're often big sample sizes with not a lot of fancy statistics. So I think they're very friendly and approachable stuff. So start there, PubMed, Google Scholar, whatever your search engine of choice is. And then from there, once I have an idea, again, so it's a condition that seems relatively self-limiting, my next step is always, if I'm unfamiliar with it, go to the clinical practice guidelines as well and see what's being recommended that way. And then I reverse backwards from there. So what's the, most clinical practice guidelines break down what studies they're using, lots of references. I'll go back to some of those major ones. So again, I'll go for an example for this carpal tunnel. I was reading about it a little bit actually yesterday. So reading a practice guideline from the Lancet from 2016, and I was unfamiliar with some of the surgical options for carpal tunnel. And so I went for that clinical practice guideline, and they were like, in their summary of discussion of results, They're like, these studies have shown better results for endoscopic release rather than open release. Click study. Okay. I've now kind of, I don't know I would have got to that paper without going to this clinical practice guideline. And like I showed you before, the clinical practice guidelines aren't perfect. Nothing is, but I think they give you a really good centralized place to start with information, because it's daunting. It's real daunting to PubMed something or Google Scholar something and see all the results that come out, right? So that's my two-step process: learn about self-limiting nature, natural history, find a clinical practice guideline, and if I need more specifics to learn more, go through those major citations through that process.
I will say the CPGs and then meta-analysis and then looking through some of those, that's a great place to start your lit search, because they've already said this group of 700 sucks. There's only 108 that work, right? And now you're narrowing your window, and then you can look at some of those that you can see repeated citations throughout the article, which means that's actually probably the better study, right? Or it may just fit their bias, depends, right? But at least you have that, and then you can go read the articles, right? So those, they already give you a literature search that's relevant to what you're looking for.
Yeah,
and
absolutely.
I do think that that's a great way to narrow your bandwidth of what you're supposed to be reading or should be reading and looking at.
Right. Like I think that ties in nicely. I think the statistics always, like, if you look at ACLR papers or ACL papers, there's like 1,500 to 2,000 a year, right? So like if you just pop that into the old search engine, you're going to have so much stuff coming up that is going to be really hard to apply to you, really hard to read and understand. So I think, and again, this ties in nicely with what people a lot smarter than me recommend, is unless you're a researcher in a specific field, you're not going to have a captive understanding of that full knowledge base. So our job is to be really good at getting to the most relevant stuff we can, not being a master of all of it, right? Like if you're someone who uses, let's say again, like there's a manual therapy focus in your clinic and you're very familiar with, Mulligan mobilizations or Maitland, whatever your strategy is, like if you're going to be an expert on those, you have an understanding of what's your clinical reasoning for using those when people are going to ask about it, whether that's a patient or another clinician. But you don't need to have read every single paper that has used a Mulligan mobilization before. You'll be exhausted, right? It's two-step process. Make it easy on yourself. Know your prognosis or general prognostics, and then big papers for kind of each condition that kind of points you in a direction that makes sense. Clinical practice guidelines are a great place to start with that. Luckily for us, we don't get super affected, because a lot of the clinical practice guidelines that kind of seemingly have issues are big sponsored ones that have like a big interventionalist focus or a big surgical focus, right? Those are the ones that tend to have some issues. So ones that are very pharma heavy, like inappropriately pharma heavy. Don't get me wrong, there's lots of times when medical inventions are very, 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 very good. So do not take that out of context, please, anyone on the recording or anything, right? But it's like, if everything is only medications for conditions that we know have alternative options as well, just something to be cognitive about, that maybe that's not the full story. It can be part of it for sure, but just not the full story. Does that I know we kind of got intended there, Chris, was that okay?
Yeah, that was great. It simplifies it, but it also makes it's, I think, like classmates and just other students I've talked to, one, they just, I think, feel uncomfortable, and they don't want to inherently spend the time doing the digging. And I think that's just the harsh reality of, like, it's never going to be handed to you with finding the answer. And if you're about to be a clinician in like a year, 2 years, or whatever, and you're not comfortable doing it, you're probably not going to do it as a new grad. And it's just like, so
I will say now is the time to develop the habit, because it really is, once you get into life and you have other constraints, if you don't have the habit set, you're not going to maintain that habit.
Yeah,
I think one of,
oh, go ahead, Eric.
I was just going to say, like, at least in our schooling, I think one of the downfalls is, I mean, one, you got to place onus on the student themselves because they're not taking the time to read the research and get a better understanding. But at the same time, at least from what I've experienced in like the 2 years of my core classes, is that they put an equal emphasis on being able to diagnose and help people with like internal disorders as they do low back pain and musculoskeletal. So now we have this false understanding that I can identify and treat, like heart conditions or intestinal issues, like things where there are specialists for a reason, where instead of learning how to refer and understanding like red flags or getting them the appropriate care that they need, we now have this like overarching theme that I can help every person that walks through my door, as opposed to staying in our lane and helping the people that we actually can potentially help. So now it's, instead of, somebody who comes in with, let's say it is GERD, being like, well, we could do lifestyle modification, but ultimately, like, there's probably other people that can help you. The schooling is saying, no, like you can treat these people. So now it's like, well, how do you like approach that as a student who, one, doesn't take any time to read the research and takes everything that the school is telling you at face value. And now it's like, well, according to my education, not only is low back pain important, but so is, heart conditions, lung conditions, GI. And now I need to know everything about everything. And it's like, well, no, like we need to be great at understanding and recognizing red flags and getting the appropriate help. But it's extremely frustrating when you have students believing that they can treat and help somebody who has like an internal disorder that, I mean, you can't replicate the pain on any movement or test. And they think, a couple adjustments a few times a week and this person's going to get better. And it's like, I think it starts at that level because, I mean, how do you overcome that type of training? You know what I mean? And like, not to be negative or say that you can't, but 150 students in my class, and we have maybe 20 who like actually want to read the research, and others who look at the professor as like this holy grail of information when they're 150 and, they've been praying to Dee Palmer their whole life. You know what I mean? Like,
so Derek, are they teaching like visceral manipulation, or are they teaching that just aligning, quote unquote, the spine allows for the natural healing of the body? What
we get a little bit. We get a little bit of both. So we had a technique that was developed at Logan called Logan Basic, where they truly believe it has like an autonomic effect, and like you can like treat like hollow organ spasms and stuff like that. Like we learn those types of things. And then we also have like the idea that different levels of the spine are associated with different types of visceral tissue and, all of those things. And even in our internal disorders classes, like the professors try and keep it separated and just an understanding, like these are the visceral like issues for GI or lung, heart, and things like that. But then the problem is they start to connect it to how chiropractic treatment can actually help these people. And in some cases, I'm like, with lifestyle modifications, like if you co-manage, I understand those things. But with most of the conditions, it's like, you're just going to spend your money here, and I really can't do anything for you. And like, our job needs to be understanding how to do a proper referral and like get in contact with the right people, as opposed to keeping them in my office and just, hoping like hell to get better. And they just don't teach those types of things.
Okay, that's fair. I was just trying to wonder if they're teaching you that you're managing that, like, because lifestyle, I'll be honest, most of the physicians I know don't understand lifestyle modification. They don't understand how that shit goes anyhow. So you're probably in the same situation, if not better than they are as far as that. Now, if you go into, okay, I'm going to a gastroenterologist and they're going to do endoscopic upper lower GI type stuff, and they're looking to see that's a totally different thing. But if you're sending them back to their PCP, those people don't have any better knowledge than you do as far as lifestyle modification, right? It's just whether or not you're sending them back to their PCP so they can send them to the GI, or if you're going to send them directly to the GI.
Yeah. It's just that, again, it's, like the cost associated with them seeing us and then other healthcare professionals, because we'll do like case studies and somebody comes in and, they end up having like kidney stones. And it's like, well, I'm just going to refer, because at this point, there's really nothing that I can do for this person. Like chances are the pain is not associated with an MSK condition. Like I'm just going to throw it out there.
Right.
And then, but the understanding is that, well, they came to you with back pain, and it's like, well, I understand, but they also have kidney stones. Like, and it's like, Like, there is no reason for me to charge this person for a chiropractic visit when we have this understanding that there is something internally wrong that chances are I can't help. So like, that's where it gets frustrating because, you know, they just don't give a good framework on like how those things work.
Okay.
At least from my perspective.
Yeah, that's fair. I'm just trying to, I'm obviously not a chiropractor, so I didn't go through all that schooling, and so I don't know how it's framed. And so that's interesting to me. Okay.
Yeah, I mean, I think the thing that's really interesting on an even broader sense is when we look at like practice pattern data, where you can see based on where people went to school, where they're currently located, and what the school teaches and how they practice is all kind of correlated, which obviously makes sense, right? You go to an educational institution, your belief is you're going to pay to learn, right? You are going to learn what you're taught. And so I think it's challenging for a few reasons, Derek, right? Because again, I think that we always run the issue of teaching to the exam at the year, right? So it's cyclical because schools will have curriculum designed to help students pass the competency exams. And then the competency exams will have what they have in the exam because the schools are teaching. And so someone's got to break the cycle of who's going to decide what's going to get broken, when everything's going to be changed, and do things need to be changed. And this is just, again, my personal opinion entirely, but I think curriculum is I'm personally of a belief that education will drive change, because I think administrations that higher up, so I think like testing boards or national committees, because they're organizations in them of themselves, have interests for themselves as well. That's just a fact, right? Like licensing board exams make money. They're a profitable organization, right? So their intent is to continue making money. That's it's capitalism in a nutshell a little bit sometimes.
Ben, do you think that schools, do you think that influence in the boards? Because I've written questions for boards, right? And I think that, when you say that there's an influence from the schools because of what they're teaching is driving what's on the question or what's on the thing. Do you think that's a selection aspect? Because none of my questions have ever been selected.
Well, I think that's entirely what it is, right? Like, I think the really classic example, and now I'm speaking on behalf of other people's experience because I'm, again, not in the physiotherapy world in the United States. But when you hear some of the faculty acknowledge at some institutions where they're saying, well, we have, we spend 14 hours on ultrasound techniques because ultrasound techniques are on the board exams, right?
Right.
And I think that definitely happens. Again, I can speak a little bit more on in my world, Canada, where again, the chiropractic college I'm at is one of there's another very small school in Quebec, but we're really the driving force of Canadian chiropractors. So our institution has the most direct relationship with the board. And so I think there's definitely going to be a reciprocal relationship in nature.
Well, that's a smaller market, right? I mean, we've got we've got 8,000 million schools. I don't know what it is now, but shit, there was 4 in Texas when I went to school, and I think there's 16 now. I mean, it seems to be exponentially gradient growing, right? And my question is, and I don't disagree. I think education has to make a change, but no educator is ever going to make a determination that we're not going to teach you what's on the test, because we're judged based off of the percentage of our people that graduate from that, right?
Yeah.
And so if that's my marketing cue is 100% of our students pass the test, I'm never going to teach what's not on the test. And if I'm writing the questions for what's on the test, and those are the only ones that are getting through because it's the same board that's basically sitting across all the universities, nothing fucking changes. It's always going to be 20 years behind. So that makes the students have to know I'm always 20 years behind in what I'm learning in the university. So I have to read current literature, understanding that what I'm being taught is for a test. What I need to know is what's current. And that's a huge burden when you're already paying ungodly amounts of money. I didn't have to pay that same ungodly amount of money. And so it's a much different thing. I'm 26 years in. We didn't pay the same dollar figures that people are paying now.
Right. Yeah. And again, I think that is the number one thing, which is kind of why so again, a year ago, I would have very honestly gotten in people's faces like, you need to know, like, you don't know this, you need to read that. I would have yelled at people. And I've really changed my tune to kind of what I talked about today, where like I think there's a way to seek out good information and not burden yourself. You don't have to love research to be up to date. I think that's like the biggest thing that I could say that I've changed. One, I used to be very critical of how people treated. I've really changed my tune on that. So hand up on that. I used to be very judgmental a year and a half ago. I'm much less so now because there's a million reasons why people do what they do. So trying to be more appreciative of individualism there, within appropriate constraints. Don't make people worse. Don't miss red flags. Like hand up, let's acknowledge that. I do not want you making people worse. I do not want you providing care that is not necessary for people. Outside of that, there's a spectrum. But yeah, like it's, I think it's so hard. Again, I'll speak to chiropractors, like, and so again, sorry for PT everyone, but if you guys don't know, like time in class for chiropractic college is like 40 hours a week. I don't know how much PT is the same. Okay. Not as much, yes, as much, Chris, I don't know, same. Yeah, we're in class a lot. We're in class a lot, like some 12-hour days of class, like straight 12 hours lectures straight, which is wild. I don't know how much learning that happens at that point, but it happens a lot. So I don't blame people at all for not wanting to know things, but I really hope, and Derek, clearly you've done a good job of putting yourself out there and finding things for yourself as well. I think the best thing we can do is because we can't directly impact any curriculum changes right now, that's obviously not within our influence. I think the best thing you do is get people involved and nudge people. Like I'm a big believer of a good nudge rather than a force, right? Can you nudge people to, hey, come to this talk. Hey, look at this. Hey, have you seen this? Because you're not going to, right? People are not going to stop treating things that they shouldn't treat. That's just not going to happen.
Well, this gets into the whole change discussion, right?
Right.
What's the epistemological aspect of what was your thought process and how you came there, and then what would it require for you to change your mind?
Mm-hmm.
Right. I mean, those are questions that you almost have to have on the table before you even try to change somebody's mind, because they go, nothing's changing my mind. Well, they're dogmatic. You ain't changing anything, and they're just going to entrench. Right. Totally. So if they say, well, if you had better evidence, and I can now provide you some evidence, right? We can do some of those things, but trying to change an individual's minds isn't going to work. They have to change their own mind. You just have to provide the resources for what that is. Right.
Right. Totally. I think, and Derek, I don't know if you've seen this. And again, this is something that from my background that I'm very proud of. So kind of like the forefront journal in chiropractic is this journal, Chiropractic and Manual Therapies. There's some publications from PT World in there as well. Really well-run journal. And they're running a special edition right now on the theme of promoting self-management, which honestly, I think is an enormous step for, again, an institution that historically is not, that's not at the forefront of management, right? That's something I think that's really interesting. I'm super excited to see what comes out of that special edition of that journal, because I think that, again, for us, Derek, and even just in general, because I don't know how much, again, I just can't speak to the PT side of things on that domain, but I'm super excited to see what comes out of it. I'm super excited to see if it sparks conversation. I don't know if it will, but things take time, right? Like it's.
Here's an odd question for you, Ben.
Yeah.
You're talking to a group primarily of PTs. Well, maybe not so much now that it's narrowed down to 6 people, but and you're from Canada, right? How hard is it to cross both profession and international barriers as far as understanding insurance, understanding all those other kind of things? Or do you think this is a universal concept that crosses all boundaries that should be across all domains?
Great question. 2 immediate thoughts. So first of all, I lived in the US for 3 years. I lived in Massachusetts for 2 years and Maine for 1. I actually went to college in Maine for a year.
Maine is occupied Canada. Let's be honest.
Yeah. Look, there's not a lot of people there. I lived in Western Mass too, which is actually also not a lot of people either. Funny enough. But I lived, I lived outside Boston because I was in the state of Massachusetts, so it's fine. So, and then another thing is my brothers lived in the US for 11 years. So because of him, he's an athletic therapist. He's worked at a college, works at a high school now. So I have a better understanding of kind of the world he occupies from his world. But then to answer the second part of the question is, I think what is not discussed a ton is that Canada is not that far off from the US. We really are the US light. There's some really interesting information that came out on that, like that health data.
Did you say US light or US polite?
It could be either one. Although I would argue that Canada's not as polite as we think we say we are, but that's a separate issue.
Okay, fair.
But there's some really interesting health spending, medical health spending data, and obviously, unsurprisingly, the US is by far and away the worst of major populated countries, but Canada's the second worst. So, right, which is really interesting because I think that in the US, I don't know, again, from my experience, people are always like, oh, wow, so different in Canada. And it's like, well, ish. The big thing is like, if I need to get my appendix out, it cost me $0. My brother got his out, it was $33,000. That is the forefront of the distance. He had insurance, some things were covered, but that's the forefront of the difference, right? But outside of that, like access to healthcare, right? Like we talked about benefits before. You mentioned like PTs have $1,000 in Canada, chiros have 500 for like 58% of the population. So even MSK issues, which we know are a big deal for a large amount of people, like we don't well support that. Whereas if you look at some European countries, everyone gets 16 PT visits a year, right? So I can't compare myself to those models. That's way easier for me to compare myself to you guys, right? The only difference, and the major difference I really think is reimbursement codes. And I know reimbursement is a lot of the challenge for some people, and what codes, in what state you're in and what codes you're billing. I know that can be a big factor in terms of, again, what insurance will reimburse that as well.
Well, to a degree, but it's still time-based.
Okay, right. So
right. Our procedurals are all time-based procedures. So
right.
It really is whether or not you're starting 8 minutes behind with Medicare or a federal payer, or whether or not that first 8 minutes gets paid by an insurance company.
Right.
Right. I mean, otherwise, the codes are still general time-based codes. They're procedural codes. I used to have discussions with physicians I worked with all the time and go, how many surgeries can you do at the same time? Because they wanted you to see 4 people. And I can't bill appropriately one-to-one time care.
Right.
Right. It's a procedure. How many procedures are you doing? How many surgeries are you doing at the same time? Well, I can't do that. Well, it's a procedure. That's why. And we're paid based off of the same. And it's not Medicare that's requiring that. It's the AMA, American Medical Association, that writes the CPT code book. So you are responsible for what I can and can't bill. So don't have this discussion with me if you don't understand what your organization is requiring of me.
Yeah, totally. And I think it's so, like, and to just expand on that final point, and I'm echoing what Jim Eubanks says a lot, and I think most people know Jim, is that just like the way to change things is stop paying stuff, right? Or pay things differently, right? If you want to see significant broad scale change, like Derek, you're asking, how do we change people's perspectives? How do we change things? Well, if people can stop being paid for doing things, right? That is a...
But you don't even have to stop paying. Manual therapy, again, I'm older than, I guarantee you, probably add 2 of you together, and I'm your age, right? But we used to all be manual therapy because manual therapy was paid because it was a higher skilled service. Right. Now manual therapy is less than therapeutic exercise, less than neuromuscular, less than therapeutic activity. And now, if you look at the literature, all of a sudden manual therapy isn't that big, right? So did the literature lead us that direction and the insurances were ahead of it? Or did the insurances lead us that direction and now the research is following? I'm not sure which was the leading indicator here, right?
Totally, yeah. And I don't think there ever even needs to be, because I think it's a constant development, right? I think one thing that's interesting is these insurance companies, the people who are adjusting rates and who are deciding the rates, things like they're not unintelligent people who are part of there looking at the research and picking apart what they should and shouldn't pay for. Right? They're incentivized and driven individuals who are very competent. There's a lot of PhDs who work for insurance companies. There's a lot of very smart people and educated people that are driving things. So I don't know either, right?
Well, there's a lot of those people working in insurance, because as a participant in insurance, I keep paying more. As a person that gets paid by insurance, I keep getting paid less. So somebody's making a lot of fucking money, and it sure ain't fucking me. So it must be those people that are doing the research to keep me from making more money.
Yeah, that's it. It's no, it's been, oh gosh, yeah. Never easy, right? We've been here for quite a while, fellas. I appreciate the conversation. Is there anything before I'm going to try to kind of wrap us up before I get yelled at for taking any more time. Chris, thanks for having me, and thanks everyone for the discussion. Like this is a very, very great use of my time. I really appreciate being invited out. And I really appreciate everyone for their contributions today. It was a lot of fun.
Yeah, thanks, man. I think you're the first Canadian to talk on here, so that's a big win. Represent.
Yeah. Population of California. So
you're originally from California?
No, I said population of California. So if you have, so not a lot of us really.
Yeah. Solid. Well, yeah, man, this was great. Thank you so much. Does anyone have any other final questions or thoughts? If not, we can wrap it up. Dope. Sweet.
Yeah.
All right.
As always, yeah, like the only thing I always say is I'm very reachable. Like I love having conversations in general about this. Again, like Paul said before too, like I don't think we get anywhere without poking into the hard stuff. And this is obviously not like a crazy profound comment, but you got to talk about it and you got to be willing to be wrong on stuff, right? Like I think the one thing I always want to close off with, I can take one last second, is like,
Chris, you should warn people that if they come on and say I'm open to conversation, that leaves them open for me following them in opening conversation. So
yeah, well, that's it, right? Like, because again, the thing that I really, this is obviously not celebrating myself, but the thing that I really try to be the most at is open to being wrong, right? So like, I'm fine if things that I don't really like if again, tomorrow, somehow there was a significant reversal in the literature surrounding ultrasound, like I'd go buy a unit, right? Like I'm not in any way, shape or form ever trying to say, don't do this if there's reason to do it, right? And I think that is, we can get a little polarized talking about stuff on social media, and there's fights over nonsense, right? There's fights over, did you do a 2-minute joint mobilization? Oh no, the end of the world.
I'm not sure social media helps anybody.
I think, well, Chris said, last thing, Chris and I were talking before you guys hopped on, but like, how many people exist in neuro PT that don't have 0% of the time ever gone in that discussion because they're out there working real hard in neuro PT and don't need to have that fight? They've already got a daily fight with all the patients who are trying to get better, right? That's the humbling.
But one of my things is we tend to put us in silos.
Yeah.
Right. But neuro PT is no different than orthopedic PT, because a neurologic still has muscle, still has bones, just like a bone and muscle still has nerves. Right. Mm-hmm. So this is a human fucking being in front of you. And I'm sorry whether that affects you or not, but the reality is your functional outcome is the same fucking thing. Can they sit and stand? Can they get off the fucking commode? Can they do these things? That's the same shit. I don't care if it's neuro or ortho. The basic stuff is still the same. Now, my stroke patient may not be trying to return to the NFL, right? Yeah. But who fucking cares? They deserve the same fucking information, the same love, the same input that I'm going to give that NFL player to get back to doing the shit shower and shave and whatever the basic level stuff is that we're trying to get them to do. All it is a variation of degrees. That's all this is. It's the same fucking human, the same fucking system. I hate it when we dichotomize things or say this person's this person's that. It's the same thing because it's a human being in front of you, bringing all the shit and complexity that a human is to the conversation. They're the experts in their world. We should be the experts in ours. And we're just trying to bridge to solve that problem.
Yeah, I can't possibly say anything to cap that. So I think I'm done.
So, all right. Y'all enjoy the rest of your Saturday. Thanks again, Ben. All right. Have a good one.
Yeah, appreciate it. Thanks, everybody. Have a great weekend.